And my husband is calling me right then. I'm hanging up on my husband. I'm keeping an eye on Mark Link. Redirecting to go to Facebook Live. It's not. Oh, it is happening now. Okay, so sorry for the wonky start on our video. This is our first HCMA official Zoom-based conversation streaming on Facebook Live. So I'm Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association. Today I am joined by three, there may be another physician joining us later, today we have represented Dr. Harry Lever from the Cleveland Clinic, Dr. John Lynn Jeffries from the University of Tennessee and Le Bonheur Children's Hospital, and Dr. Theodore Abraham from UCSF. And we are going to be trying to discuss a very complicated matter. And I'm going to give it an intro before I let the doctors kind of guide us through this very interesting time that we're living through. So the question is COVID, hypertrophic cardiomyopathy, and back to school. What should we be doing as an HCM community in these very complicated medical times? So there are a number of considerations that we're going to be talking about. Number one, for children going back to school, for families sending children to school who have somebody else in the house with HCM, and for teachers and faculty members in schools who happen to have hypertrophic cardiomyopathy themselves. What should we be doing for each of these silos of individuals? We are going to talk about things that are very regional right now. So we're going to have to take your own regional considerations into account. You're going to have to also take into account individual HCM conditions, specifically in children. Is there restrictive physiology? Is there obstruction? If that's the child situation, if it's at home and a parent has HCM, are they going for myectomy, devices, transplant evaluation? What is your HCM status right now? And then we're going to look to the guidance that we're getting from the federal and state levels for each region, and obviously federal is all of us. And the information is not 100% clear right now. This is not a political conversation in any way, shape, or form. We are here to discuss what is in the best interest of those with hypertrophic cardiomyopathy as it pertains to going back to school. So with that being said, I will add one more statement, and that is, this is not a black and white issue. There are 1,000 shades of gray, and we're going to hopefully help you pinpoint some thought patterns and some questions and some conversations to have with your physician and with your school system. So if I can ask my participants to unmute themselves, if you could first just tell us who you are, what institution you're from, and a little bit of a state of affairs COVID in your region. Now we'll start with Dr. Lever. So unmute yourself, Harry. All right, wait, you're not asked to unmute. You're still muted. Hold on, let's see if I can ask to unmute. You have to do it yourself. It won't let me.
So, can you hear me?
Can hear you now.
Yeah, but you can't see me.
I can see you, we're good.
I can't see you.
That's okay, we can hear you.
Okay.
So tell us where you're from and what the COVID status is right now in your area.
Well, I'm in Cleveland, Ohio, and we are we're county by county, it's different. There are about 11 or 12 counties that are red. Cuyahoga County, where I am, is red. And they're still trying to, actually the Cleveland schools have announced that they're going virtual. Then there are a bunch of suburbs that have made some choices. And some are saying you can go either way, and others are saying it's just going to be virtual. So it hasn't been finalized yet.
Okay. Ted, let's hear from California. What's going on?
Hi, good morning or good afternoon. Ted Abraham from University of California, San Francisco. California, as most of you have heard, is seeing somewhat of a surge. I hope you can hear me okay.
I can hear you okay. Just one second. Harry, you're joining again, but you're already here.
I know, something happened. I was just trying to get the picture here. I'm sorry.
Okay.
I lost it.
All right. I might have you back, but I might duplicate you.
All right.
I'm sorry, whatever. Ted, go ahead.
Go ahead.
That's okay. We're having somewhat of a regional surge here in California. As of last week, most of the surges happened in agricultural areas and in certain institutionalized situations like prisons. But in the cities, there was a urban surge that seems to be flattening out. However, as far as COVID itself and schools are concerned, all schools will be remote and there will be no in-person schooling when school starts. There is no anticipation as to when that rule will change. We're obviously closely following at the city, county, and state level. And we anticipate that maybe in a month or so, we'll know more about how the situation evolves. When schools are concerned, all schools will be remote and there will be no in-person schooling when school starts. There is no anticipation as to when that rule will change. We're closely following at the city, county, and state level. We anticipate that maybe in a month or so we'll know more about how the situation evolves.
Okay, so as I said, this is my first attempt of doing this live on Facebook, and I hit a button and I have two screens going right now, and if there's feedback, I apologize. That's my fault right now. So I'm not quite sure how to end this thing that I'm doing here. 1 second. I don't know what happened. I'm so sorry. So as I said, this is my first attempt. So now we're doing this live on Facebook, and I hit a button, and I'm. Give me 1 second, guys. I'm so sorry. If there's feedback, I apologize. So I wanna end this. So I'm not quite sure how to do this. See all. Close thing that I'm doing here. 1 second. I don't know what happened. I'm so sorry. 1 second, guys. John, you're up next for a regional update, but I want to make sure that this is not. Give me 1 second, guys. I'm sorry. So I want to end this. I'm going to turn down my volume for a second, and I'm just going to run with that. John, go right ahead. I'm so sorry.
No problem. So I'm in Memphis. I see both children and adults with HCM. Just to give you an idea of our region, so we're at the sort of the configuration where we see people from Arkansas, Mississippi, Tennessee. So in Tennessee, there are about 100,000 cases that have been diagnosed and about 1,000 deaths. A quarter of those have been in my county, so in Shelby County. So we are actually, our incidence numbers seem to be on the uptick right now. No doubt we're doing more testing, but I think just purely the hit rate and the incidence is actually going up. And so we're becoming more cautious. We had sort of opened up, as you all probably know, some states in the South had planned a more aggressive reopening, and Tennessee was one of those. And that's has been scaled back simply because there's so much going on currently. On the pediatric side, we have been seeing some cases here. We haven't really experienced this inflammatory syndrome that we've been reading about, and the children that we have seen have recovered, thankfully. But we know we have to be cognizant of all of the ages and be able to supply the right kind of care to mitigate the virus.
So now I'm going to have to go back and forth between mute because I'm doing a watch party and streaming live, and someday I'll figure out how to do this. Okay, gentlemen.
Can you show me my picture?
Should we be sending children throughout the United States back to school in the beginning of this semester? Is this a good idea or a bad idea, or is it a regional decision that people need to make? Cast your votes now. No, Ted's a no, they shouldn't be back to school. John is, what do you think, John? He's a down. Harry, are you a thumbs down?
Yeah, I don't think so.
Okay, so we don't think people should be back to school yet. I'm sorry, Harry, say again.
Can you get my picture back?
You're on screen, it's just your computer, you can't see yourself.
Oh, okay.
So you're good.
All right.
Ted's a no, they should be back to school. John is. So I'm going back and forth with my volume. I apologize. Someday I'll become an audio expert while doing these. Today's not my day. Okay, so we don't think they should be going back to school. But if a family is left with a situation where parent must go to work, child must go somewhere. Is there, in your opinion, any safe or safer way to accomplish that? Okay, Harry's saying a no.
No.
Ted, what do you think? Is there a safe way to send your child back to school if there are no other alternatives for you?
I'd say it's not the best idea. Clearly, social distancing and masking are the two things that have worked to reduce infection rates and the spread of the disease. So it's ideal not to have people congregate, and schools would be a perfect, or rather in the wrong way, a perfect environment for the wrong reason. So I would say no as well.
Yeah, and I would agree with Ted and with Harry. I think, but we also know reality isn't always what we want it to be. And so I do think if people are in that scenario, hopefully, one, they are being managed by, an HCM center that obviously Lisa could provide those data for you if you need it, and have a really frequent bidirectional communication with your providers, I think is going to be absolutely critical, because life is life. Some people are going to have to probably experience this. And I don't agree. I agree it's not optimal at all. But I do think you want to make sure that you have the ability to communicate with people that are going to help you if there are concerns, if there are symptoms presenting. What are you going to do? Where are you going to go? How are they going to treat you? And I think that's of the utmost importance.
Okay, so the consensus of HCM experts is it's probably not safe to go back to school yet, but if you have to, the general precautions need to be really followed. And that would include transportation to school, that there has to be, a reasonable way to get the child to school. School buses are probably not going to be the answer. Walking in hallways, shields, masks. But what if somebody coughs on your kid's sweatshirt and then that sweatshirt comes back into your house on that child on their return to home? Should you have classroom protocols set up? Should you have sanitation set up? Should you have ways to have that child return back from school, strip down in a safe area of the house, put their clothes in a bag, bring it to the laundry, and bring that kid immediately to a shower to disinfect them from what they might have brought in? These may be the realities that become your back to school practices if you have to send your child back. Now I'm going to pivot to an item that Harry and I talked about briefly as we were entering this call, and that is the teachers and the teachers' unions. I know in New Jersey, they're making some statements about what should happen and what shouldn't and how concerned they are. And we're in a plateauing and on the way to the right answer, low COVID rate state. And there's still a lot of concern. So to our panelists, should teachers with HCM try to do distance learning and work in that capacity, or should they not enter the classrooms at all? What should teachers and faculty members do with HCM? We'll start with Harry, then go to John, then go to Ted, and I'm going to mute myself.
I've had two teachers, and I've told them both not to go back. One of them in particular was really a bad situation. She was told that the parents voted that the kids should be 3 feet apart, didn't have to wear masks in class, and the only time they had to wear the mask was in the hallway. And I said, that's totally unacceptable. And I reported that to the state of Pennsylvania. I haven't heard back from them. But that was in a town 70 miles east of Pittsburgh. And I just couldn't believe it. So I said, that just didn't make sense. She had had coronary artery disease and hypertrophic cardiomyopathy, and I didn't think it was worth the risk. Particularly since there's a delay in testing, and the question comes in now, if somebody gets sick in the classroom, do you have the capability of testing the whole class, and how long is it going to take to get the results? And that seems to be the weakness in the whole thing, is that nobody seems to be able to test quick enough to get the results unless you're a baseball team. And even those guys, the Miami Marlins apparently had 14 guys that have it, and they've been testing daily. So I think if you can't test, you can't deliver a product.
Yeah, I think Harry's spot on. I agree completely. I've had I have a middle school teacher who we've given similar advice, is I just don't think they should be there. And I also have a university level PhD instructor, and I gave them the same advice as well. And I think distance learning is appropriate. And Harry's point is absolutely on target. Is if you think about it, how can you adequately test everyone, and how frequently are you going to do that? I mean, no one really knows these answers. So you're going to test everyone every day in a school system becomes somewhat cumbersome and unrealistic, I think, at least right now. And so I do think caution needs to be observed on both ends, both the teacher and the students.
And Lisa, I agree with both Harry and John. I guess the only statement I would add to what they very eloquently put forth is that look at what the hospitals are doing for most places. Certainly our hospital, one is we have a screening tool. It's a bunch of questions with symptoms. If you have those symptoms, you don't want to be in a situation that you could potentially put others at harm. That's number one. Number two, masking. There's this beautiful thing infographic on Twitter, on Instagram, where if you speak and hold a petri dish in front of your hand, you get infected. If you cough, it's even worse. If you sneeze, it's even worse. But if you put a mask on, there's almost no infection. So that just shows you how effective masking is. And right now, our internal policy is you're at risk if you were with someone who ultimately gets detected with COVID, if you've had a distancing of less than 6 feet and for more than 15 minutes. That's considered high risk, and we then have various protocols in place. And the last comment I want to make to some of the comments made about testing is that I just had a patient, not HCM, but I was going to do an aerosol generating procedure on them. They had an initial COVID negative, a second COVID negative, and the third time we were going to do anesthesia-induced TEE, a transesophageal echocardiogram, and anesthesia insisted on a third test. And guess what? That third test came back negative. So none of these tests are 100%, and they're never 100%. And repeat testing might not be concordant with what your first couple of tests were. So
no, the third one was positive. Third one was
yes,
positive.
sir. Correct.
No,
third was positive.
No, it was positive.
I'm sorry. Yeah, third was positive.
Positive. Right.
The first two were negative. The third one was positive 96 hours after the first test. And it was anesthesia that insisted on that. Again, this person was from San Quentin, high infection rates, over 60% positivity rate in that population. But testing is not 100%, and you're not going to get tested at the rapid pace you want to do that. So for all those reasons, I think we come back to where distance learning is probably the most prudent way to approach this when school starts in fall.
Okay, I'm back listening to one version of this conversation now. This has been a little confusing for me, I must admit. So we don't know when the schools are going to test. We don't know how long it's going to take to get test results back. So if you were to send your child back to school and somebody in the classroom has a fever, you have to expect that it's COVID until proven otherwise, which could take 10 to 13 days right now. So none of this is looking really functional for patient with HCM, be them a student or be them a faculty member. And it's a lot of worry and concern for the non-HCM person in the household, or the non-school going student or faculty member, teacher, to your spouses or other family members living in the house, what you're bringing back in. So I think we've pretty much concluded that for HCM, for the fall semester, distance learning, homeschooling is the best option for both faculty, student, and for the health of the person in the home with HCM who might end up getting infected because of what they were made contact with through the school. Now, I'm going to kind of dive into some other spaces here, because you watch the news, you read the scientific literature. There's some disconnects between the two right now. And I believe in scientific literature and clinical trials and peer-reviewed literature and these types of mechanisms to help me make decisions. So I'm going to pose the question, and we're going to go round robin again. And on my screen, it's Harry, John, and Ted. So that's the order we're going in. Number one, can you please comment on, number one, do you think a vaccine is coming before January? Number two, is hydrochloroquine a legitimate treatment for hypertrophic cardiomyopathy? And number three, what are we learning about how COVID affects the heart? And what about these cases of myocarditis? And can they have long-term impact on an HCM person should they become infected? And I'm going to go back on mute, and I'm going to hand that to Harry. So number one, two, and three.
I don't think the vaccine is going to be available, and we're not going to know that it's safe till it's just too early, I think, at least from what I've read. The hydroxychloroquine doesn't seem to be safe in patients with heart disease to start with. And I think that it's questionable in people who don't have heart disease. So, I mean, there's this QT prolongation that we're worried about. And if you develop heart disease because of the virus and you start the drug, then, nobody knows. I mean, it could cause lots of troubles. And it's just been, there was initial unreasonable expectations. And I can remember when the FDA allowed this one drug on the market, the one hydroxychloroquine manufacturer on the market came from a company that I never would have used anyhow. I think it was coming from Pakistan or someplace, and it just wasn't useful. So I think the one hope that we have is they're talking about on the news, there is this test that's going to be able to be done at home. So it'll be like doing your blood sugar and, testing yourself in the morning. And if you're okay, go to work. Next day, test yourself, no good, stay home. And I think that's what's going to have to happen. Otherwise, all these other ways of doing it is just not going to work. And it's not clear how quickly that's going to come. Some people are saying it's going to be, but then they got to worry about distributing it and making enough of it and all that kind of stuff. And that's why we need, logistic people to handle that kind of problem.
Yeah, I agree with Harry completely. I think people forget the fact about how vigorously vaccines are researched, and that's post-use, meaning, what are the potential downsides or implications of a vaccination? And there's no way we're going to have that information, no matter what kind of modeling or anything else we do. We don't have real world data. So I think everyone would have to say, are there safety concerns and what is the real benefit? We don't really know what is the long-term benefit as far as an immunogenicity when we look at a vaccine. I'll speak more to the ped side because I know Ted will speak to the adult side as well. Remember, there are no formal recommendations for pediatrics and COVID currently, none. So they're working on it, and we've tried. I'm helping a little bit on the cardiac side, but we don't really know. And so I think the cardiac implications could be devastating. And that's someone with no underlying phenotype, right? So on top of all that, we really just don't know. And there was a nice article in the New England Journal talking about multi-organ system in pediatric patients. And it's pretty impressive, and it can be very highly heterogeneous. And so I don't think that we have enough information at this point. And talking about a vaccine, we're going to give vaccinations to a 2, 3, or a 3-year-old when we don't know the long-term implications. That's a big question. And as a parent, I would really want to know as much as I could before I made that decision.
He's muted.
Thank you. Very nicely stated both by Harry and John. I couldn't agree more. I'd say the Moderna vaccine, which is being tested at the NIH, just graduated to sort of technically phase 3. But to both my colleagues' comments, we don't know what that means. We don't know what the side effects are. And it will be at least 2 to 3 years before you know early, not even the late consequences, just the early efficacy is going to take 2 to 3 years. So I hearken back to the historic perspective here. If you look at the Spanish flu of 1918, the tale of the two cities that has been often quoted in the Twitter sphere and in the lay literature. St. Louis implemented very early isolation and masking, had a few thousand cases, few hundred deaths. Pittsburgh, hit at the same time, did not have masking, did not do isolation, several thousand deaths. So right now we know that if you do not mask and don't socially distance, early models said one person can infect 5.5 people. If you mask, that is reduced to sort of one person. So instead of a 5-fold increase of everybody, you infect 5, those 5 infect 25, you have 1 to 2. So I think for the next 2 years, that's going to be very important. Does that mean we're not going to go to school or do everything else? No, maybe there is a way and means to smartly and effectively open up the country and open up commerce, but do so in a means that there's no magic pill here. You know, I know there's anecdotal cases where hydroxychloroquine has worked in the hospital. There have been cases, they're very anecdotal. Would these folks have gotten better on their own? We don't know. Did hydroxychloroquine and Zithromax actually make a difference? We don't know. There's no randomized trial. And I'd say that some of our colleagues in cardiology who published this literature that ultimately got withdrawn and retracted did a disservice to the community by whatever they did, because that just gave more fuel to the people that say that these drugs might be effective. But the real answer is whether it's drugs or vaccine, there's no early answers. There's not going to be a magic pill that's going to solve our problems in the next 6 months.
Thank you. Okay, so to summarize, vaccine hopefully coming soon, but maybe some home testing that'll help us identify who should not be out in public and thereby not be a spreader. But vaccine may or may not be an answer long-term because we don't know how long the vaccine is going to last. We don't know the impact on the vaccine on children, and that needs to be studied, and that's going to take time. So thereby, we really can't hold that out as the hope to get schools back together is just by having a vaccine. And we know through data that's been published around CDC and other sources, only about 1/3 of individuals are willing to even take a vaccine once it becomes available, because we have so much misinformation circulating about safety of vaccines overall. So we can't wait for one answer. So the question of hydrochloroquine, I know the FDA did their small study on that, and it was pulled for utilization in COVID because of adverse effects, and they pulled it off the market in other countries as well. And now we have some individuals who are in a newly formed, as of 2 weeks ago, nonprofit organization calling themselves, I believe, Frontline Medical Professionals or what have you, which, by the way, are funded by a very polarizing aspect of our political spectrum. So that brings into some question as to what their motives actually are. But claiming that hydrochloroquine is in fact the answer when the peer-reviewed literature and the clinical trial structure does not seem to support that at this time. Would you guys agree that that is a very fair way to paint that new addition to our conversation as of yesterday or the day before when it took place? Is that a good assessment? Yes? Yeah, okay.
The other thing to mention is that everybody should get a flu shot this year.
Yeah.
And the other thing to think about, nobody has said much about it, but if you get early symptoms of what seems to be the flu, you should take Tamiflu and try to abort the episode. And on the other hand, we may have less problems with the flu if people wear masks this year. So maybe neither one will spread as much if people wear masks. And maybe this should be a lesson for the future in flu season. Once we're past this horrible problem, maybe we ought to be wearing masks when we get flu season and we won't get as much influenza.
I want to say those are fantastic thoughts, Harry, and fully agree. And I think, you know, I still remember a lot of our friends in the Far East, they're almost obsessive about wearing masks for many years or decades. And I still remember wondering, you know, are they being overly paranoid? But maybe that is going to evolve into the best practice, that if you have symptoms or people around you have this, wear a mask for a few weeks and you might be better off and might serve the community better. So great points.
Yeah, and I think Harry's point about flu as well is, even in our own system, we're talking about you are going to have to think about concomitant testing, right? Because the
Yeah,
symptoms,
right, exactly.
so you have to think about both. And it may be an opportunity for HCMA and the people on the call to educate their providers and reinforce that, this could be something else. And there's something that might shorten the duration of this if it really is influenza. So I think it's absolutely important. What Harry and Ted said are absolutely on target.
Okay, so I have a question that's coming to us through Facebook. And for full disclosure, this is coming from the teacher in my own family, my nephew. And he said, if a teacher had to enter the classroom, and have to is a key word here, and I'm going to pause and say employment may be on the line. Access to health insurance through your employer may be on the line if you do not return to work. So in some cases, there are some very difficult financial decisions that need to be made. So we will put an asterisk on the have to. We'll claim that that's the definition of have to. Enter the classroom. What would you tell them to protect themselves and their students in the classroom that they may not already be aware of at this time? Should shields be utilized by teachers? And should you put up protective plastic barriers between students? How far should the seats be apart? How often should the rooms be disinfected? These types of questions. We're going to go round robin again, and we're going to start with Harry.
I think the visor is important. We've started at the clinic. They've ordered them where they're waiting for them to come in, and everybody's gonna be wearing a surgical mask and a visor. And I think that may help. Now, I don't know how this visors fit on smaller kids. That we'd have to see. I don't know the answer to that, but that may help to really to do that. And I think the desks have to be 6 feet apart. I think that's what the studies have shown, that if you're at least 6 feet apart, you're.
Would you put shields? I saw a picture of plastic shielding, PVC pipes with plastic, so the kids are, while they may be far apart, there's also an extra splash shield, like at
It's
a
like everybody
bar.
being in their own
Should
telephone
the salad
booth.
bar protect your children from germs of the kid next to them?
It's like being in your telephone booth, but then the problem comes in, it costs money, and I'm not saying not to do it, but you have to have time to install it. And you've got to have, there's been, I think, a shortage of plexiglass. You've got to be able to, as a matter of fact, I have a model train thing, and I needed a little bit of plexiglass, and they warned me that I just needed a small piece, and I ordered it from somebody. They said, oh, it's going to take a little while because we have such a run on plexiglass. I said, okay. But that's a problem too. And I mean, they're doing that in grocery stores and things like that. And, so as a result, it's making a run on that stuff. So, but I think, anything you can do would probably make it safer, but then each kid, and then you got to make sure with how high it is, and can the kid hear, if you have, is it going to interfere with what they can hear and that kind of stuff. But it's going to take, I'll figure the tubing and all that. That's time and money. And if you're going to do it, you better do it. You got to get moving. But lost you,
Lisa. I think you're muted.
I'm muted. I was calling you out. What do you think?
So interestingly, we actually have been using the visors for all of our providers for any patient interaction over the last week or so. So we have a mask and a visor. But Harry's point's right, is what's the availability? Do you have all these sorts of things at your disposal? And you brought up something about cleaning, right? How do you do that? And that's something I think people are still trying to figure out. So does every room need a UV emitter or something where you can actually go in and clean that way? And how long and how frequently? So I think Harry's right, is anything that you can put up in theory will be beneficial, right? But you have to be compliant too. And remembering school age kids, are they going to be, consistent with wearing masks, with visors, all those sorts of things? I don't know. I don't know. And not saying that anyone, I think these ideas are great, but it is about implementation. As Harry is saying, it takes time, it takes money, it takes resource. And once again, I mean, this is conjecture. We're just using common sense to say that we think that would probably make a difference. So the question is that still going to get us to where we would be if we're doing distant learning or distant teaching? And probably not.
I agree. Again, great thoughts by both John and Harry, and I don't have too much to add. We have just started as of 2 weeks ago adding the face shield, and I think that's a great idea. We've always done masking. I agree with both Harry and John about the comments on plexiglass. I think it's going to be very expensive, and there might be an availability issue, and implementation, as John mentioned, is what counts. Every single classroom in funding constrained public classrooms is going to be very difficult in my mind. You want to do the best you can, which both my colleagues have mentioned: distancing, masking, face shields, maybe a shield for the teacher, but all the kids, are distanced at least 6 feet apart, and do the best you can. Most classes are crowded, so I don't know how you're going to achieve that. Do you do extended hours, staggered hours so that kids are separated? It's going to be tough, but if you're mandated, if you're going to lose your job and your insurance, I think that's the best way other than distance learning. I think distance learning clearly would be the standard and the recommendation, but if you're forced to and there's no other way and you have to be there, do all or any of the components, and every one of them counts and is additive, and hope for the best.
Okay, so you see me leaning, I'm turning down my volume all the time, so sorry about that. All right, so now I want to spend a few minutes where I'm kind of answering the questions that I'm seeing come along. I'm not seeing them all because I'm not seeing both feeds simultaneously, because like I said, it's the first time I did this. The myocarditis that's associated with COVID. I'm going to tell a cautionary tale. This is an N of 1. So for those not used to scientific literature, this happened once that I'm aware of. It does not mean much when it's only one case. But we had an individual actually lived close to me in northern New Jersey, and he was a very low risk HCM patient in his 60s, no risk factors known, very basic course of HCM, pretty uneventful. He got COVID in March, recovered in April, and had a cardiac arrest in May. There was some thought that there might have been some myocarditis type activity in his heart during the COVID, and that out of nowhere, somebody who had been evaluated by people you all respect and found to have zero risk factors has a cardiac arrest after developing COVID. We don't know enough to know that there's a causation here and that there's anything one meaning the other. They could have been completely unrelated activities. But it does make you wonder if myocarditis, which in layman's term, inflammation of the heart, we know COVID can cause inflammation in the lungs. We know it can cause inflammation in the heart. What do you guys think about an HCM heart that is impacted by COVID? And what should we be thinking about there long term? I know this does not have a great answer. This is just conjecture and hypothesis right now. There's nothing in the literature on this. There's an N of 1. One person had this happen. Does not mean that it's connected at all. But what do you think we should be thinking about HCM, COVID, and cardiac implications that are nothing to do with HCM, just COVID? Who wants to start? Harry's shrugging, so I'm going to give it to Harry to start with again.
I don't have a good answer. I think I'd be liberal use of the MRI and see what it looks like over time and see if the heart scars. But I don't think we really know. But we do know it seems to be a vascular virus, and it certainly can affect blood vessels. I mean, I just heard of a case in Harrisburg, Pennsylvania, where the patient was 55 years old and he had his fingers and toes amputated because he lost circulation. So who knows? I mean, the heart obviously depends on the coronary arteries, and we don't have enough information to know.
Yeah, I would agree. I mean, I think you have to remember other common causes of myocarditis like parvovirus infect the endothelium, and that does cause coronary thrombosis. So, in HCM, if you're compromising vascularity, that's a problem. The other thing is remember some viruses are cardiotropic and they may target the myocardium and they may be there for a long period of time. And who knows when that might reactivate, quote unquote, right? So that's what Harry's alluding to is that, we do have MRI diagnostic criteria for active myocarditis, and we can follow those patients longitudinally. I think it's going to be hard to know. Yeah, but the flip of that is you have someone you think has COVID and you're going to expose your MRI scanner to that patient. How are you going to deal with that part of it too? So there are checks and balances. There's no doubt it would be great to have the imaging, but how does that affect everyone else too? And, and what is it going to mean longitudinally if you have edema and whatnot? I don't think anyone knows. So I think surveillance is going to be key. But I think as we know from other viruses and myocarditis, you can't reliably predict that people are okay, quote unquote, reaching out 10, 20, 30 years all the time.
I agree with both John and Harry. I think I'd say that in your example that whatever ill effects were probably related to COVID rather than HCM because it's just so rapid in someone who had such low risk and was a borderline or a mild case of HCM. But that doesn't mean that COVID doesn't alter at the cellular level, as John just mentioned and Harry prior to that, that it doesn't alter the cell's behavior, reactivity, processes, and pathologic processes. And now you have two heart conditions. You got myocarditis and HCM, both of which might combine synergistically, again, adversely and produce effects that we don't know. It would seem like COVID would be responsible for the immediate effects, but COVID interacting with HCM might be responsible for the more delayed effects. And I would suggest that maybe the best thing is to do surveillance and understand more about the disease, but also de novo risk stratify them. In a reassessment, if they now fall in a high risk category because of this combination, maybe we need to think differently than what we thought about a month before they got COVID.
Okay, so I am going to welcome
Dr.
Mark
Link
to the call.
I think Link has joined.
Yes, Dr. Link has joined the building or the Zoom meeting. So Mark, I think we might have had a time issue here. And Mark, if you can unmute yourself, I'm going to ask you to unmute. And I'm not sure if Mark is live or frozen. Oh, Mark is off the picture on my screen. So let's see what happened. If we can get Mark Link live. I think we may have lost him. Mark, I'm asking you to unmute. We'll try to get you back in here in a second. So I'm going to, let's see if we can just get Mark back on, ask to unmute more, ask to start video. He's on his phone. So such is the life of the busy electrophysiologist in Texas. I was hoping we would hear from Dr. Link to give us a Texas point of view as to what they're doing with schools down there. We'll try to get him online in just a minute here. So I've been evaluating and kind of looking at the questions from the community to clarify some of the issues. If you're going to do face shield, it's mask and face shield, not one or the other. It would be the two together. You would never wear a face shield and not a mask. The overwhelming consensus of this meeting thus far has been schools should be virtual for everybody with HCM and those with HCM in the family. If you need to, if your school district is opening and you either have a child in the school district, and we lost Mark, you either have a child in the district or you're a teacher in the district, or you have a family member that works in the schools and comes home to you, I would seek a letter from your HCM specialist requesting that you be permitted to be a distance learning teacher and that you can handle that aspect of your job. And we can keep it there. Ah, Mark Link went to his desk. Okay, so I'm going to ask Mark to unmute himself.
Okay, sorry.
And Mark, hi, welcome.
Thank
So
you.
I'm going to ask you to give us an update of what's going on in Texas with COVID and give us your input on what you think we should be doing about back to school. As you're late, you didn't talk to the other people in this meeting, so what you're saying is completely independent. Let's see how close you are to what they said.
Okay. So we don't have any problem with COVID here in Texas.
Oh, I see.
It's all a figment of people's imagination.
Right.
And fake news. Actually, Texas, as most of you know, Texas is a hotspot right now, just like New Jersey and Massachusetts and New York was before. In Dallas County, which has about 3 million residents, we're reporting 1,000 to 1,200 cases a day. And it's gone down a little bit in the last 3 or 4 days, but clearly Texas is an epicenter at this point, so much so that if we go to New Jersey or to Massachusetts, we are quarantined for 14 days. So that has definitely played into the public's mind. I will say that mask wearing down here is pretty good. I mean, we're in Dallas, but it's pretty good. You go to the grocery stores, it's 95, 98%. There's been a very contentious debate about schools. With some people, including parents, pushing to open up schools for everybody in 100%, and other people pushing back. What Ken Paxton has said, our lieutenant governor, so not our governor, Abbott, is that regional boards do not have the authority to delay school openings. He said that's a state issue. So that was kind of a surprise to a lot of school districts around, that the school district themselves will not have the authority to delay school. So currently, schools are on. Schools are on for late August and September. There are some school districts that are allowing parents choice to have virtual or Zoom school or in person, but schools are on down here.
So Mark, we have a problem here. Texas schools are on. Your colleagues here said school shouldn't be on because it's too dangerous and we're going to add to transmission. But in Texas, they're saying game on, go big or go home, and they're going to open schools. So we've given some cautionary tale to those who must send their children in to consider such things as how to stay safe during transportation, how to manage hallway time, and what happens if somebody sneezes on your jacket when you're walking down the hallway because their mask slid or what have you. Should there be partitions in the classroom? When and how should those partitions been cleaned? What happens if somebody's found to have a fever that day? Is it assumed to be COVID until proven otherwise, which can take 2 days to 13 days or more, depending upon where you are. We talked briefly about the home testing kits that might be available someday. So do you think, although the schools are opening, do you think it's reasonable and safe for them to open at this point? Or do you think you're going to see your numbers go up in Texas? Obviously, this is opinion. This is not fact, but your gut as a physician, what do you think should happen?
Yeah, my gut, and I think this is backed up by science, is when you have congregations of people, transmission occurs. So I don't see any reason to think that schools are immune from that. In fact, I think you could argue schools are even more susceptible to that because the younger the individuals, the more likely they are to be asymptomatic. So you're going to have more asymptomatic COVID spilling teenagers, and they're going to spread it to their friends. And I'm not so concerned. I mean, that part, those people the AIDS don't tend to get sick, but then they're going to come home and give it to their parents and grandparents. That's where I'm in particularly concerned, because then, the parents and grandkids can really get sick. And, we're seeing teenagers die of COVID too. It's not like teenagers are immune. And even teenagers without underlying conditions can get really sick. So yeah, I'm very concerned about schools opening. So we'll see. I think it's another one of these experiments. Texas, I think, opened up too soon, and that's what brought. The numbers in Texas were going down. We were not a hotspot. We were actually relatively low. We opened up, and as we opened up, and it wasn't just the opening up that was the issue. It was the kind of appearance that it wasn't a concern anymore. So it wasn't just that people were catching it in restaurants because they opened up 50% capacity. The bigger issue is that people stopped worrying about it. So they congregated in their homes, they congregated at parties, they didn't wear masks because the impression was that it was over. COVID was over. We had defeated it, and now we could go back to daily life. So they weren't catching it in restaurants. They were catching it in, congregate with parties at their homes. And I think that's the issue for school. You're going to have transmission that occurs in the schools. It's going to spread to the community.
So Mark, I'm gonna pause here. I am having a little bit of an audio problem on my side. You guys don't hear it, but I do, because we're streaming on Facebook and I'm getting it through both feeds. So I know you kind of stepped on you there a little, sorry. I do have a question for you specifically as an electrophysiologist. Specific to hydrochloroquine and a Z-Pak for the treatment of COVID. Do you think this is proven to be effective in any way, shape, or form? And do you think this could be potentially dangerous to certain populations?
So I think the data that has come out has shown that it has no efficacy whatsoever. And there is clear risk. There's risk in the QT prolongation is the major risk. And we're seeing this reported, we're seeing this published in the Lancet, in Circulation, a number of articles that are showing us the risk of hydroxychloroquine, in particular when it's given with azathioprine. So I don't think there's any role for it anymore. In fact, I don't know of any of the randomized trials that are still ongoing. I think they've all shut down because of no benefit and potential harm. So we can give all our Plaquenil back to the lupus patients and the rheumatoid patients, and we don't need to take it anymore.
Thank you. Okay, so I'm hearing you both through this. Okay, I'm turning that down. So I'm going to wrap up this crazy conversation that's gone on for an hour now with final thoughts. So final thoughts, and I'm going to add one category that somebody just asked a question about: college students going back to frat houses and dorms. Good idea, bad idea, and best advice to families in this time with HCM and COVID and trying to get back to a semblance of normal. And let me make a final statement before I hand you all off for your final statement. I don't think any one of us wants schools closed. I think we all want everybody to be as normal as they possibly can, put kids back in school where they can academically achieve, socially achieve, and continue to build upon themselves as individuals. We all want that, but we all want safety, and we want to make sure that we're not transmitting a communicable disease through our communities, through being, myopic, that it's not really going to affect the kid that bad. So let's pretend it's not going to affect anybody that bad. I think we need to be cautious, working towards safe openings, hopefully sooner than later, but we have to get these numbers under control, because right now there's not going to be any semblance of normal in our lives until these numbers come way down. So what do we do about college students? Because we know how well they listen to not going to parties and things like that. And what are your final thoughts about where we are today? And I'm going to go, because I'm going to put myself on mute. We're going to go Harry, John, Ted, and Mark. So Harry, back to you.
Well, I've heard some schools are taking dormitories and making sure there was only one student per room. They've gone out and they've rented hotels or whatever to have, again, one person per room. That sounds somewhat reasonable, I guess. But again, this is a technology problem that we just don't have enough technology and supplies and all this kind of stuff. Howard University apparently was going to be doing in Washington was going to be testing on campus. They got a company that's going to come in and do it, and they'll be testing once a week or something like that. But I think that we have a problem. And then certainly college age students know how to use computers. And I think that's the safest way to go about it. I mean, everybody's using computers these days. And, I think that we've got to understand that life is different and we're going to have to learn from on the computer. I mean, look how much using computers all the time for everything. So, I mean, I've never used computerized banking till March of this year. And now I'm an expert on doing banking from the computer. I mean, I'm not, not writing checks and not doing that kind of stuff. So, I mean, you got to change. And I think we've got to do it the safest way possible. And in reality, if we would isolate for a month to 6 weeks and really do it tight, other countries have shown that's how they've been able to get it down. And that's ultimately what has to happen. And the longer you wait, the harder it is to do it. And there's one other quick thing I wanted to mention. I've come to know an expert in Cambridge, Massachusetts, who deals with pandemics. And he said that 6 weeks and it'll go down. The other point he made, and I don't know how others feel about it, is you can make a quick diagnosis if the patient has it with a CT scan of the lung. If you get anything on that chest x-ray, you got a problem, and the result is almost instantaneous. Now that takes a lot of, technology in terms of CT scanners and all that, but maybe in some places that's a quick way to say you got it. And certainly, and those people have to be looked at very carefully, because there's some people that get short of breath. They suddenly get short of breath really fast and they're in trouble. Yet they probably had bad lungs that they had, it got in there real fast and they had no warning. So that's another thing to think about.
Yeah, I would agree with Harry completely. I think the other piece that I would ask people to be cognizant of are a couple of things. One is, what about all the people that are asymptomatic? So really knowing all of this is still just completely in the fog, as far as I can tell. We're not doing antibody testing on everyone. We don't know how reliable it is, as you've heard prior. The other thing I would say is that we do continually say, this age group, these comorbidities are most prone to a significant morbidity or mortality. I'm saying, I think we don't really know enough about that in the younger age populations to say that they're not going to be affected. The longer this goes on, the more cases we will see. You're putting people together, and it's always some sort of a bell curve, right? Are there going to be people that do completely fine? Of course. Are there going to be people that do horribly? Of course. And we don't want that in our young people, in our adolescents, in our kids, and in our college age students. So I think Harry made some very good points. We have to be thoughtful. We have to be united in how we approach this.
I agree with Harry and John, great points. And thank you, Lisa, for getting this group together and organizing this. I think it's just timely, appropriate, and very informative. But I don't want to add to, or repeat what Harry and John have said. I'd say, one, University of California has decided across the largest university system in the country will only have distance learning. And I think that should be the gold standard. But if you do need to be in the classroom, I think we talked about some of the measures that would reduce infection rates. Number two, I'd say that vaccine and testing are unknown. We don't know when vaccine will come about, how effective, how good it will be. And testing, as we talked about anecdotally, lots of negative tests in the presence of an infection. And the last point I want to make is I'm hoping that the historic perspective is not lost and that we follow history, whether it's the Spanish epidemic 100 years ago, whether it's SARS a few years ago, or MERS. All of them, had a huge flash. Luckily, they were limited in geographic distribution, unlike COVID. But I'm hoping that it gets to a point where this is a smoldering, simmering fire, not a raging forest fire, and people will continue to get infected but not die from it or have serious complications. That vaccines will at least be partially effective, and that the world will return to some semblance of normal. But I think it'll be a new normal, not the old normal. But again, thank you, and it was a delight, chatting with the colleagues, Mark, John, and Harry, and thank you again, Lisa, for putting this group together.
Yeah, so I don't think there's one solution that goes across the board. For example, my daughter is going to be a senior at Carleton, which is a small liberal arts school, and her class sizes are going to be very, very small. And so they've already said that they're going to have a combination of Zoom and very, very limited class sizes where there'll be no one sitting within 6 feet of each other. And even then, you'll have to wear a mask. That works for a small college. That doesn't work for the University of California, which has class sizes of, 500. So I don't think there's a universal thing. I think the underlying key is you have to do everything you can to prevent infections. And I'm concerned. I'm actually a bit more concerned about high school than college, because at least if a college student gets it, they don't bring it home. But I'm very concerned. This is a pretty bad virus. And I do think that many people aren't taking it seriously enough. And that's a concern for college. Again, it's the impression that if you give the impression that it's not dangerous, then kids are far more likely to congregate and have parties. It's going to be very hard to prevent parties. I got to tell you, that's no matter what you do to classes that come Friday night and Saturday night, kids are kids. I mean, their brains aren't developed. And that is going to be a big concern, whether or not you have Zoom meetings.
I want to ask one question, and I've thought about this and haven't gotten anybody to help out with it. I've often wondered if we shouldn't have public service announcements on TV showing what the lungs look like in this disease and really scaring people that there's a problem. This is no monkey business. This is what's going to happen to you. And I wonder, I've often wondered if the medical societies somehow shouldn't get together and do that, and say, look, this is it, guys. No monkey business. And this is what's going to happen to you. I had an experience with my wife. She wanted to know, what do the lungs look like in this disease? So I went to Google. I put down acute respiratory distress syndrome. And my God, do you get pictures of all the, what it looks like? And I said, that's it. And I mean, it's shocking when you see it. And I wonder if we haven't done that, and I wonder if there's not some mechanism that we could get the American College of Cardiology or the AMA or somebody to do that. And once and for all say, this is it, guys. This is what's going to happen.
I think that's an excellent idea. And I think there's this massive unknown about, and we know how it infiltrates the lungs. It's pretty dramatic when it happens, but we don't know what other organs it's infiltrating long-term.
Right.
We don't know if, how many people have come to you guys as physicians and said, I don't have a family history of HCM, but my great grandfather had rheumatic fever and had a mitral valve problem. And they think that it's not connected to HCM, and it might be, and it might not, but it could be rheumatic heart. Are we going to have COVID heart? Is there going to be some damage that is long-term from the myocarditis? We don't know yet. And if you're talking about somebody with HCM or any other type of structural heart disease, and then we're adding something else maybe on top of it, or taking healthy hearts, giving the myocarditis and seeing what happens long-term there, these are really interesting questions that are going to take decades to figure out. It would not surprise me if in 15 years, people are coming to the doctor saying, I have these weird symptoms. And, now we have COVID heart or COVID lung long-term and COVID lung short-term. So we don't know what these things are going to do to us long-term, but we do know that we are, and I hate to sound catchphrasey, we are all in this together. Whether you're in Ohio, Texas, California, Tennessee, or you're in Europe, China, Japan, Russia, we are all dealing with the same virus. We are all dealing with the same fact that there's lots of coexisting conditions that we're going to have to navigate through COVID. So for our population right now, and I'm going to summarize what we've talked about in the last hour pretty abruptly. Yes, some school systems are going to open. HCM experts generally agree that this is probably not a great idea right now. We would like to get the numbers way down before we reopen schools and start that mass spread of virus again through schools and our children and our faculty. We want to keep everybody safe. So if you are in a position where you have to get to school, you have to send your child to school, however you define have to, that's an individual choice. Masks, proper hand washing, face shields if possible for teacher and student, social distancing, making sure that the transportation question is handled in advance. Buses are bad. Drop your kids off at school if you have to. Make sure that there's a protocol for picking them up from school as well. And that brings into the concern that they're going to have their clothes on from school, and that's now in your car and you have cross-contamination. So it just doesn't seem very viable that schools can open safely and not deal with spread. So try to homeschool or virtual learn. If your school district is open and you have people who are very compromised HCM wise at home, ask for a letter from your Center of Excellence coordinator or cardiologist to assure that you're given an opportunity to do home-based learning. Even the top administration of this country said if you have coexisting conditions such as heart disease, you should be homeschooling. That was last week. Their advice tends to change with the wind, but they did say that last week. So I'm going to take that one to the bank and cash it and hope that many of our HCM families are able to do home learning or teaching from home and hold on to their jobs and benefits, and we keep each other safe. If there's any other comments from the crew, by all means, speak up. I thank you all for taking the time to join with us today and help educate our community. And any final notes?
Great job.
Goodbye.
Keep it up, Lisa.
Okay, great work.
Thanks, guys. Have a great day.
Yep.
Okay.
Bye-bye.
Bye.
Thanks. Thank you. Thank you.